All right, we're going to get started. My name is Jennifer Craig. I'm one of the educational consultants at Patton. I am thrilled that Dr. David Chi is here to do a webinar on the genetics of hearing loss. He is the clinical director at Children's Hospital for otolaryngology. He is also in charge of the Hearing Center. He is a cochlear implant surgeon. He is the father of three, correct? Three boys, which is also another full-time job, which I'm sure is thrilling every day too. So I'm going to turn it over to Dr. Chi and we'll get started.
Oh, thank you so much, Jennifer, for the invitation. Glad to be here and to take some time with you and to discuss a topic that's relevant for all of us who are interested in this room. And during this time, it should be viewed as a discussion as much as possible. Feel free at any time if you want to stop and ask me a question. We'll also leave some time at the end to answer questions if you rather save it for the end. I think with COVID, let me see if my slides are advancing.
Try clicking on the picture once and then advance that way.
Okay.
There you go.
Yeah, thank you. Well, with COVID, I think we all recognize that the world has been totally flipped. We never did all these Zoom conferences or Teams conferences. We have Teams meeting in the evenings. But I think we've all been comfortable with that. And again, I'm delighted to have this in a Zoom-like format. One of the interesting things before COVID was that if someone was advertising toilet paper with pizza, that would be the ultimate red flag. And we would want to report that to the state for some potential health code violations. With COVID, toilet paper with pizza is actually very appealing. And this is one of our pizza shops right near where I live in Wexford that is now advertising for toilet paper with pizza. So the objectives of our presentation are straightforward. The first and most importantly, we want to understand the importance of hearing loss. And we will go over and identify the differences between syndromic and non-syndromic hearing loss. And we will recognize some of the common syndromes associated with hearing loss. And then we'll describe some of the types of genetic hearing loss. So everyone in this room should be familiar with this. But hearing loss is the most frequent birth condition. 6.1% of the world's population is affected somewhat by hearing loss. And 1 to 3 of 1,000 live births in the United States are with moderate to severe hearing loss. That equates to approximately 12,000 infants born annually in the United States with sensorineural hearing loss. And this is about 35 babies per day. An interesting fact is that 90% of the infants with hearing loss actually have hearing parents. So a lot of these parents are not prepared for this diagnosis. A lot of these parents aren't familiar with what hearing loss is. And so we as educators, professionals, healthcare providers have an opportunity to share what the information on hearing loss is with these parents. One of the best ways to view hearing loss as an infant is that it is truly a neurodevelopmental emergency. We have an opportunity to intervene when they are diagnosed early because early intervention has significant benefits. There are some classic studies that demonstrate this. This table graph shows that in yellow what the normal grade equivalent should be for a child with hearing, with normal hearing should be. There should be a one-to-one progression in age to years to the grade equivalent. In red is a slope for children who have hearing loss. And one can see that there is actually a decreased slope, decreased progression in age and years and their grade equivalent. There was this Hallmark paper by Yoshinaga and Tano in 1998 that compared children who were diagnosed with hearing loss between birth and 6 months and those who were diagnosed after 6 months. And they both received the same intervention. And this is the results. that those who were received and diagnosed between birth and 6 months had better receptive, expressive language skills, and this was independent of age, gender, socioeconomic status, and ethnicity. So that is the impetus for the Universal Newborn Hearing Screen. States, including Pennsylvania, have pushed for the newborn hearing screen, and the goal and the mantra is 136. We want to screen by 1 month. We want to have an audiological diagnosis by 3 months, and we want to have early intervention services started by 6 months of age. As you know, the JCIH published some recent guidelines, and they recommended that for those states who are doing well with the 136 to be challenged to push it to 123. That is to screen by 1 month of age, then to have the audiological diagnosed by 2 months of age, and to have the early intervention services by 3 months. So this is a common question that we face in the Hearing Center clinic. And maybe you face this in your professional interactions with the families with hearing loss. And they come and they ask this simple question: what caused my daughter's hearing loss? And when we break down the etiology or the cause of hearing loss, it can be broken down to 25% can be an acquired cause, 25% can be an unknown cause, and about 50% is thought to be genetic. This genetic half can be further broken down. 2/3 of them can be non-syndromic, and 1/3 is thought to be syndromic. And the more than 500 syndromes that have been identified. And syndromic basically means that there's some associated findings or symptoms associated with the hearing loss. Our goal of this presentation is not to go over 500 syndromes. That would be very exhausting, but is to go over some of the more common ones that we may see and be familiar with. And for some students, these are the ones that you very well may be asked about in board exams or test questions. Typically in a live session, we could point and ask each other what the diagnosis is, but we will just go over this one by one. This is a 2-year-old girl with sensorineural hearing loss and syncopal episodes. And this is the EKG obtained on this child. And to point out on this EKG, for those who are not familiar with them, this is the QRS complex, and this is the T wave. And there is a long elongation of the QT interval, and that has been associated with syncope. And when we do see this with associated sensorineural hearing loss, the diagnosis is Dravet and Lang-Nielsen syndrome. This was first described in the mid-1800s by Meissner when a patient who was a deaf-mute girl in the Leipzig Institute for the Deaf collapsed and died while being publicly admonished by the director for a misdemeanor. There's some outdated terms in that, but it just highlights the diagnosis that this may be the first described Dravet and Lang-Nielsen syndrome. The prevalence is 1.6 to 6 per million. And again, the diagnostic criteria is a prolonged QT interval, which is associated with syncope and sudden death and was described in the 1950s. It is on chromosome 11. And once identified, the mortality rate is less than 6%. Nowadays, it's actually associated with certain genes, and it's KCNQ1 and KCNE1 are some diagnostic tests for Dravet and Lang-Nielsen. Here's our next syndrome. A 3-year-old boy with sensorineural hearing loss and a large thyroid mass. So whenever we see and hear about goiter, the diagnosis is Pendred syndrome. It is autosomal recessive and was first described in the late 1800s by Pendred when he characterized an Irish family in which 2 out of 10 children were with hearing loss and goiter. The goiter or the large thyroid is not always present, and it can be associated with inner ear malformations, specifically the Mondini and the large vestibular aqueduct malformation. Pendred also has been mapped to chromosome 7q. There's a mutation in SLC26A4, and there's actually a gene test that's available for this condition. It encodes a protein pendrin, which transport chloride and iodide. And the diagnostic test is a nuclear medicine study called the perchlorate discharge test. This is a picture of a eye, the back of the eye, in a child with sensorineural hearing loss and blindness. And just to point out, this is the optic disc. These are the vessels, and there are these pigmentations that are occurring in the retina. And this condition is Usher syndrome, and occurs in 1 in 6,000 births. There are 4 main types, and the diagnostic hallmark is retinitis pigmentosa, which is a pigmentation of the retina. The diagnostic test is electroretinography or electronystagmography. This table describes the 4 types and is based on the onset of the hearing loss, the severity of the hearing loss, and if there's some other vestibular symptoms. There are 9 different genes associated with Usher syndrome, and one of them, MYO7A, has been the cause for type 1A. People ask, what is the retinitis pigmentosa and what is the blindness associated with Usher? Well, the onset is not at birth and affects both the rods and cones. As we remember, rods are for night vision and cones are for the bright light and fine detail and color. RP, or retinitis pigmentosa, affects the rods first. Therefore, the individuals with Usher syndrome will first have poor night vision, then they will subsequently have difficulty with the fine details and color. This is another syndrome, a 2-month-old who comes to clinic after failing newborn hair screen. His mom reports that he had a patch of white hair when he was born, but that went away. This would be the typical appearance of a child with Waardenburg syndrome. And the features are dystopia canthorum, which I will describe shortly. They have a flat nasal root. They have the unibrow look, or the confluent eyebrow. They may have the heterochromic irides, which means that they have different color eyes. They may often have this white forelock. They have pigmentary changes. They may have diminished vestibular function, and they may have cleft lip or palate. It is inherited in an autosomal dominant fashion, and the incidence is 1 in 40,000 live births. There are 4 different types of Waardenburg syndrome, and again associated with this dystopia canthorum. Type 4 is associated with Hirschsprung disease, which is a congenital condition that may be associated with neural changes in the large intestine, and they have difficulty having a bowel movement requiring further surgery. It is thought that 2 to 5% of infants with congenital deafness may have Waardenburg syndrome, and in those with Waardenburg syndrome, sensorineural hearing loss occurs in 20% of the cases. So what is dystopia canthorum? Well, basically it's referring to the distance between the eyes. Normally, we should have the normal interpupillary distance between the eyes. In hypertelorism is when the interpupillary distance are set apart. They're far away. In dystopia canthorum, the pupils are actually at a normal distance, but the medial canthus, or the inside part of the eye, is actually displaced outward to give the impression that the eyes are far apart. Here's our next syndrome. A 5-year-old boy with history of urologic surgery and history of neck surgery for cysts has sensorineural hearing loss. And this condition is brachial otorenal syndrome, and the incidence is 1 in 40,000. There are some features with this syndrome. Namely, they may have preauricular pits, they may have branchial anomalies or neck masses, they may have outer or inner ear malformation, like this boy with this cupped ear formation, and they will have some kidney malformations and dysfunction. The hearing loss in BOR, is that majority may have conductive hearing loss. About 20% will have sensorineural hearing loss, but half of them will have the mixed hearing loss of both the sensorineural and the conductive component. There's actually a gene test for this as well, and that is the EYA1, which is a gene that's associated for development of the kidneys and the inner ear. There's another condition that's associated with renal dysfunction. This is a 4-year-old boy with hematuria or blood in the urine and subsequent diagnosis of progressive glomerulonephritis or swelling of the kidney, and has bilateral sensorineural hearing loss. Whenever there's a term progressive glomerulonephritis and sensorineural hearing loss, we have to think about Alport syndrome, and 80% of the time is inherited in an X-linked fashion. Previously, it was with a clinical diagnosis. We needed 3 of the 4 features of a family history of hematuria or blood in the urine. There needs to be some EM evidence of glomerulonephritis. There needs to be a biopsy of the kidney showing the inflammation of the kidney. There needs to be a high frequency sensorineural hearing loss and some ophthalmological or eye findings that's associated with Alport syndrome. Nowadays, this can be also done with some genetic testing with the COL4A gene test, which is a collagen gene or a structural gene that's associated with Alport syndrome. I'd like to highlight 3 other trisomies that we may encounter in our practice or in our experience with our patients. First one is one that we're all familiar with, trisomy 21, Down syndrome. And the main aspect is that a lot of these children will have middle ear disease. They may often need ear tubes because of fluid in the ear. But about 35% of these children will also have permanent hearing loss. And of those with hearing loss, about 34% will have sensorineural hearing loss associated with their Down syndrome. Some of the other less common trisomies is trisomy 18 or Edwards syndrome. This is the second most common trisomy and occurs in 1 in 7,000 live births. The features of Edwards syndrome are cardiac defects, short eyelid stature, small mouth and jaw, and a clenched fist. And this picture shows that with the overlapping fingers. Hearing loss occurs in over 50% of these little ones. Trisomy 13 is Patau syndrome. It occurs in 1 in 10,000 to 1 in 25,000 births, and they have more severe features. They may have microcephaly, they have the small eyes, they may have cleft lip or palate as this child demonstrates. There's heart defects and hearing loss. So we're not going over an exhaustive list of syndromes, but I would like to highlight this in this table. On the far left are the different syndromes that are identified and the different inheritance patterns and the clinical features. But the main point I want to make with this with relatively busy slide is that historically, there were some clinical tests that were used to diagnose these syndromes. There was some EKG or the electroretinography or a perchlorate discharge test. But now it's a shift. There's more and more genetic tests for even some of these syndromes that have been identified and can be tested in the clinic. Now we'll deal with the majority of the genetic causes. Again, 2/3 of the genetic causes are thought to be non-syndromic. And of these, it is about 70% autosomal recessive, about 15–20% autosomal dominant, about 2–3% X-linked, and a small fraction, which is mitochondrial. And I'll go over each of these to make them a little bit more clear. So how do genes work? How do genes work? Well, genes are the roadmap for proteins. We are all familiar with the DNA, and that's where our genes are located. And these are maps that help to build the proteins in our body. And proteins are everything, whether it's the hair, muscle, It could be structures in the cells that are important for the function of our body. Each child inherits half of his or her genes from one parent and the other half from the other parent. And if there are any defects or mutations in the gene, then the protein itself is not normal and does not function, and hearing loss may result. We'll go over each type. First of all, is autosomal dominant. When we hear the word autosomal, it refers to the fact that genes are on one of the first 22 pairs of chromosomes. Our 23rd pair is the sex chromosome, but the first 22 pairs are the autosomal chromosomes. And one parent usually has a hearing loss. This figure depicts in red the individual who has the autosomal dominant hearing loss here. And the females and males are equally affected. The parents will have 50% risk of transmitting the gene to their child, as here is depicted here. So 50% of their children will have autosomal dominant hearing loss. In general, the hearing loss with autosomal dominant causes are milder, and in general, they may start in the second or third decades of life and usually may allow for normal speech and language development. When we look in the literature, the medical literature, and see the word DFNA, that is referring to an autosomal dominant cause. DFN is referring to the deafness gene, A is for dominant, and there are over 50 different locations identified for autosomal dominant hearing loss. The more common cause of inherited hearing loss is autosomal recessive. Approximately 70% of individuals will have autosomal recessive hearing loss and requires inheritance from each parent. The parent, he or her, will not have the hearing loss because they themselves are carriers. And females or males are equally affected. This cartoon depicts how each parent is a carrier and they do not have hearing loss. And they will pass in 25% of their offspring, they will both get the hearing loss gene and will have the hearing loss. The other 3 will be normal in hearing, with 2 of the 3 being carriers themselves and 1 without the hearing loss gene. In the scientific literature, when we see the letters DFNB, that is referring to autosomal recessive. DFN is referring to deafness, B is referring to recessive. And there are over 75 loci identified that are for autosomal recessive hearing loss. We'll spend some extra time talking about one of these autosomal recessive hearing loss. That is connexin 26. That is DFNB1. That is the first mapped autosomal recessive hearing loss, and it's to chromosome 13q, and is associated with a mutation of the gene GJB2. And then GJB2 encodes for a connexin protein, connexin 26. For some populations, this mutation is associated with 40% of genetic hearing loss. And the carrier rate in the Midwest United States is 2 to 3%. That means that when we have perhaps 100 people on this Zoom call, 2 to 3 of us may very well be carriers for this gene. So what is connexin? Well, connexin is a gap junction protein. And the best way to view it is like a docking station for the cells, for 2 cells to connect to each other. 6 connexin proteins form what's called a connexon. So that is where these little connection occurs between 2 different cells. And electrolytes, secondary messengers, and metabolites may pass through from one cell to another. Gap junction proteins are in various structures of our inner ear. And it is thought that the loss of the ability to circulate potassium in the inner ear causes the cells to eventually die and lose their function as a hair cell. There's various different mutations in GJB2 that have been identified, and is based on ethnic makeup. The majority is the 35del G mutation. There's the 167del T mutation that will become more common in Ashkenazi Jews. And for me, it would be 235del C. People ask, what is the hearing loss with connexin or GJB2? Well, typically, these individuals have prelingual or before the onset of language, bilateral non-progressive loss. The hearing loss may very well vary from mild to profound, but the severe to profound is the most common. Only a small fraction is mild, and if you do have the 35del G mutation, it is thought that it is more severe than those with non-35del G mutations. The third type of inherited or genetic hearing loss is X-linked recessive. It is with DFN. When it does not have the letters A or B, that means that it is an X-linked cause. And the prevalence is less than 2%. And there are 5 different map loci that have been identified thus far. The main hallmark is that there is no male-to-male transmission. This pedigree depicts what X-linked hearing loss is. The male is the square, the woman is the circle, and if they are with the carrier, there's a circle within that. So the woman is always going to be a carrier. They themselves will not express this, but when they do pass it on to the son, they will express the trait. And 50% of the sons will express it. 50% of the daughters will all be the carriers for the trait. And that's how the main hallmark is of the woman will be passing to 50% of her sons to express a trait, and 50% of her daughters will be the carriers of the trait. There is no male to male transmission because the father will only pass the Y chromosome to the son. They will not pass the X chromosome in which this gene is associated with the hearing loss. One of the clinically relevant X-linked recessive hearing loss is this mixed deafness with perilymphatic gusher. There is this mixed hearing loss, and whenever there is a middle ear surgery called stapedectomy, there is a risk of a gusher or progressive hearing loss with this surgery. This CT scan shows the internal auditory canal, and it is actually, for those who've seen them a lot, it should be nice and thin, but this shows how it is very bulbous. And this is associated with the leak of the fluid into the out of the ear whenever there is the stapes surgery. And surgery for stapes is not recommended in these individuals. There's actually a gene test called POU3F4 that's available for these children if there's a suspicion of this condition. The fourth type of genetic hearing loss is mitochondrial. And we have some unique DNA within our mitochondria. Mitochondria, to go back to our school biology classes, we have a cell and we have the mitochondria within the cell. And there's 2 to 10 copies of ring-shaped pieces of non-nuclear DNA within the mitochondria that's inherited maternally. If a woman has the disease, all of her children will be affected because she'll be passing this through her inheritance. If the man has the disease, none of his children will inherit it because that is primarily only inherited through the mother. The mitochondrial DNA, again, is only inherited maternally. Usually the hearing loss is associated with syndromes, but there are 2 that's worthwhile to mention. There is the A1555G mutation, which makes a child predisposed to have aminoglycoside ototoxicity. I think it's fascinating that we used to think that aminoglycoside ototoxicity is only an acquired cause, but it actually may be a genetic cause for some individuals. The mutations in mitochondrial systems are associated with energy production, tissues with high energy requirements such as muscles and the cochlea. And these are the ones that are especially vulnerable. There are some syndromic conditions that are associated with mitochondrial inheritance, and they may be associated with lactic acidosis, stroke-like episodes. They may have some muscle issues, and as one can picture, these are associated with hearing loss and muscular disease and mitochondrial inheritance. So a frequent question that we get asked and we try to think through is, what is the appropriate workup for hearing loss for a child? Well, previous to any genetic test, the history and physical was thought to be essential, but it only identifies the cause in about 20 to 35% of these individuals. Then there was a shotgun approach when we ordered every laboratory, every imaging scan to determine the cause. But it turned out it's like looking for a needle in a haystack, and the yield for some of these studies were extremely low. So I'll explain what is currently done at Children's at Pittsburgh as well as around the country. History is still done. We still need a comprehensive history. We need a prenatal history, understanding some of the teratogens, some of the potential drugs associated with hearing loss, maternal infections, and metabolic or nutritional issues that may be associated with disruption that may affect the child. There's a perinatal history that we'd like to know about. Were there any events at the time of birth? Was there hypoxia? Was there a placenta previa or abruption? Was there prematurity? Was there any low APGAR scores? Was there any birth trauma? Was there any neonatal jaundice that required treatment, or neonatal infections that warranted IV antibiotics such as gentamicin or aminoglycosides? The postnatal history is also important. Were there any infections afterwards that warranted admission for IV antibiotics? Were there any speech and language problems for some of the individuals that indicate some hearing loss? Is there any family history of hearing loss? That is hearing aid use early on, such as before age 30, the stigmata of syndromes, or were there any history of consanguinity, which is not uncommon in our state of Pennsylvania when we have the Amish population. Also essential for the evaluation is the physical exam. We look for any ear anomalies that be indicative of syndromes, eye changes such as synophorus, which is the unibrow dystopia canthorum that we heard about, the color of the eyes, retinal pigmentation. Is there any face asymmetry, or are there any other conditions that may be associated with syndrome such as cafe au lait, which is associated with neurofibromatosis, and any digital anomalies that may also be an indication for syndromes. So the diagnostic test, as we alluded to, is some laboratories, the genetic screen, and CT and MRI. And currently, these are the ones that we get. We don't routinely get laboratories unless there are some indication to do so, such as any renal dysfunction. Then we'll proceed with urinalysis or BUN creatinine. We do offer genetic screen to everyone, and we consider imaging on everyone. And we'll highlight some of the genetic components. This is one of the battery of tests that one can get for genetic hearing loss, and it is very comprehensive. And this allows us to identify all the different potential causes from genes associated with hearing loss. And people ask, why would you do genetic testing? Well, it has the highest yield. 40% of severe to profound prelingual hearing loss may be explained from a genetic test. It provides some reassurance for families to know that there is a diagnosis, and it provides some genetic counseling for some families who would like to do some family planning for future children. It may obviate the need for laboratory testing since there is a conclusive diagnosis that other tests may not be necessary. But there are some limitations, and namely, if you do get a genetic test, it's not therapeutic. The results of gene tests does not change the hearing loss. In addition, even if the test is negative, the cause may be still genetic because that gene may not yet have been identified. And lastly, there's some costs. The genetic test for each individual test may be about $300. To get a whole panel test is roughly about $3,000. So it has to be factored in with the insurance and the family's desires to pursue with the genetic testing. So what is the future of genes? Well, as we mentioned, it's non-therapeutic currently, but hopefully in the future, there may be some options for those who want to pursue it for some gene therapy. It is promising in animals. Basically, we're delivering the abnormal or absent gene back to the patient. And there's some recent studies that have come out that continue to demonstrate the possibility of this. This cartoon depicts how one of the genes, SNYE4, was delivered via a virus vector to a mouse who had the defect in SNE4, and it rescued the hearing function. These are the ABRs of these mice. The far left here is the wild type, those that do not have hearing loss, and we can see the typical waveforms. Those with the SNE4 absent mice had the hearing loss with no discernible waveforms until perhaps way up above 80, 90 decibels. And this is the one in which the gene was returned back to the mouse, and you can see that there is restoration of the waveforms, almost mirroring the normal ABR. So what is the workup in 2021? Well, we all start with the history and physical and the audiogram. We lean on our audiology colleagues to have a comprehensive audiological testing. And if the diagnosis is certain, then we don't necessarily do any further workup or etiology. And they get the appropriate treatment, and they all ultimately end up in the same point of the eye exam, early intervention, hearing aids or cochlear implants for those who desire to move forward, and then the appropriate follow-up. When the history and physical and the audiogram is not as clear, then it depends on the laterality of the hearing loss. When it is a unilateral hearing loss, we don't always pursue with genetic testing because the likelihood of that is low. But we do offer radiographic imaging and that CMV testing. When it is bilateral hearing loss, we do have a genetic clinic, and we refer them up to a same-day genetic clinic for them to have an evaluation for a genetic cause. And we also do imaging and CMV testing for those who desire to move forward. But then ultimately, we do the same management for their hearing loss. So in conclusion, hearing loss is the most common birth condition. Genetics is the most common cause of sensorineural hearing loss. And we as healthcare providers, caregivers, professionals, counselors should be aware of the syndromic and non-syndromic hearing loss for counseling purposes, but also for referrals for associated conditions that are associated with the hearing loss. This is a link of some of the sites referring to the genetics of hearing loss that's available. And I thank you for your attention, and I'll be open to any questions.
Dr. Chi, there was a question. Is it possible for fraternal twins for one to have a hearing loss and the other to have normal hearing?
Fraternal twins?
Yes.
Yes, indeed, because they may be viewed as two separate individuals if they're fraternal, and they will have a different genetic makeup. And so they may be viewed as two separate children born at the same time.
Okay, and the next question. Are you aware of any research into regrowing hair cells?
So that's ongoing work. As you know, this has been done in avian models or bird models for regeneration. And there's still ongoing work. Is it to a point where it's applicable in humans? Not yet. I think those are some exciting frontiers that we could still look forward to in the future. But as of now, that is not something that is clinically available but we can always look forward to that. It'd be a great time for those who want to have the hearing to not even need technologies such as hearing aids or cochlear implants in the future. But for as of now, that's something that we will continue to strive for the different signs.
The next question is, can a child have Waardenburg syndrome and Usher syndrome at the same time?
I guess there's always a possibility of that. I think the likelihood is probably going to be low to have both of these, but there is a chance. I'm not sure if the person who's asking has encountered an individual with that, but there's always a chance for that. Highly unlikely. There's this concept of Occam's razor, where you have one diagnosis that unifies all the diagnoses instead of having two diagnoses. But of course, there may be some rare situation where someone may have two separate chromosomal syndromic elements that may unfortunately affect them.
And we have another comment about another syndrome that this person's aware of, Turner syndrome.
Mhm.
A little bit about what that is.
Turner syndrome is when the sex chromosome, you are X0 or XO, and this actually has various manifestations. This phenotypically or visually, the child will look like a girl, but they have other features such as webbed neck, short stature. Sometimes some cognitive issues may be associated with this. And there are reports of the hearing loss that has been more common in the Turner syndrome. There's different manifestations. Some will have a conductive component, some will have a sensorineural component, but as again, one of the other syndromes that can be associated with some degree of hearing loss.
Okay, and have you found that certain syndromes have better or poorer outcomes with technology, such as a hearing aid versus a cochlear implant?
Yeah, I think because some of the syndromes are associated with some structural changes, such as if there are some inner ear malformations, they may not do as well with the cochlear implant. Namely, there's a condition called Charge syndrome that's often associated with inner ear malformations, which makes surgery challenging, and as well as maybe the outcomes or the surgery a little bit more limited. The other aspect that may affect performance for children with syndromes is their cognitive function. If there are some more cognitive impairment from their syndrome, then they may not do or perform as well with a cochlear implant or with a hearing aid, because some may be resistant to wearing the device, some just with the cognitive limitations, which is also important in their outcome. They may not do as well with the hearing aid or a cochlear implant.
Okay, and the next question, would you recommend a teenage patient with unknown cause to repeat the genetic testing after no genetic cause was detected at the time of diagnosis at birth?
So it probably depends on what kind of genetic test was done at birth. Even 10 years ago, some centers only did the Connexin screen alone. If they only did a single gene test, then they may not have tested for the other screening for other genes associated with hearing loss. And if the family is interested in moving forward, that should be an option that can be discussed. And then the second step is to make sure that the insurance covers it so that the family is not potentially with an expensive bill for this genetic test. At Children's, we actually draw the blood work, but we don't send it off until insurance approval occurs, so that the families are not incurring a four-figure bill for these genetic tests. So I think in that situation, that teenager, it really depends on what the comprehensive test was performed. We don't expect that the genes have changed from when he was a toddler to now a 17-year-old, but the tests that were performed may have changed. And that, for that reason, if they were not done comprehensively, that should be a consideration for the family if they want to pursue it.
Great. Well, I don't see any other questions right now. I have a question, actually. I know that you guys are now, working up kids with unilateral hearing loss for cochlear implants. Are you seeing more kiddos and families pursuing that route as it's becoming more mainstream?
Yeah, it sure is. I think, as everyone knows in this audience, that the cochlear implants are now, first of all, it's been approved for unilateral hearing loss. And we're seeing that more and more as a indication. I think there are some that are ideal candidates for unilateral hearing loss. These are the ones who are older, who may have lost their hearing for whatever reason, whether it's from trauma, infection, or some anatomic changes that associate with hearing loss, like an EVA. And they are accustomed to hearing with 2 ears, and they want to go back to hearing with 2 ears. And they are the ones who will probably receive that and understand that well. If there is a child who's now 17, for example, using that age again, and they are always with unilateral profound hearing loss, we'll be very reluctant to offer them a cochlear implant, just as if there were a 17-year-old with bilateral hearing loss wanting a cochlear implant. That nerve and ear hasn't been stimulated for so long that we're not quite sure how they would do, and we would probably counsel away from them for a cochlear implant if the duration of hearing loss was that long. So those are one of those individuals are very ideal. Now, the main question is, what about the newborns who are now diagnosed with the unilateral profound loss? And it hasn't actually been approved for that indication, but that is something to consider as we're learning more about this. It harkens back to the early, around the 2003 or 2004, when we first did bilateral cochlear implants. And you only got one implant for the longest time. But I think it's just emphasizing how we value the importance of hearing with 2 ears, for the hearing and noise, sound localization, opportunities that are afforded when we can hear with 2 ears instead of one. So I think we'll hear some more and more data about the increasing indications for unilateral cochlear implant for unilateral hearing loss. Just as we're seeing more indications for residual hearing loss, even in pediatric patients. And the new generation of cochlear implants seem to preserve the hearing better. And I think surgeons are more aware of techniques to preserve the hearing of the residual hearing for cochlear implant recipients.
Well, I don't see any more questions. I want to thank you so much for presenting to this group today. I think we have audiologists, teachers of the deaf, supervisors, a whole different bag of people on this call. And I think the information you presented was wonderful and very useful. So I hope someday you'll come back and do this again for us.
Sure. Really enjoyed it. And ideally, we'll have some face-to-face interactions again once everything is safer.
Absolutely, that would be wonderful.